Morning. Thanks everybody for coming so early.
Cell phones and pagers.
It's hard to talk about the esophagus at 6:45, but I'll do my best. Turn these lights down a little bit. Don't go to sleep. All right. Slides are a little dark. Okay, stage 2 on the esophagus. Not the most attractive subject matter today, but it's something that's on your exams, something that was on my thoracic exams every time. Some of it is mundane, some of it is not. So we're going to go over EGD, esophageal gastroduodenoscopy, which I think you'll get most of it Conway. Do you? Y'all do a fair number of them? Great. Well, this will be helpful, I hope. I do EGDs on every esophageal case that I am asked to perform because you don't want any surprises at the GE junction. That's the last thing you want to do is take your specimen out and you thought you had a 39 centimeter lesion and you take it and you cut across an esophageal cancer. So I think it's very important to do your own esophagoscopy. And you'll be able to get privileges when you go to a private institution or another academic institution to be able to do your own. So I think it's important to get pan-endoscopy privileges, if you have them, for bronchoscopy, EGD, and colonoscopy when you get there. Now, there's some turf battles out there in the real world that may not allow you to do all of them, but normally they will acquiesce to surgeons who are very interested in doing their own endoscopies, just preoperatively. We'll go over esophageal motility disorders, which are tough entity. I see a lot of them. You guys may not see as many because I see them in the differential diagnosis of chest pain. Acute MI, STEMIs, non-STEMIs, dissection. Some of these people come in with dramatic pain that can be very similar to those entities, and basically they have some esophageal motility disorders. And I'm not a foregut surgeon. I'm up at esophageal hiatus all the time with esophagectomies and the aortic hiatus, but I will briefly go over reflux surgery. Now, this is a huge entity, and it's a new specialty if you think about it, operating on the distal esophagus, the stomach, the duodenum, and the first portions of the jejunum. It really encompasses foregut surgery, and we'll just be talking about the esophageal portion of it today. EGD, mundane but nonetheless important. Patient selection. This first slide is very important. These are called alarm symptoms of anybody, and they increase the indications for endoscopy, especially upper GI endoscopy. So many of the upper GI endoscopies have been overutilized that you end up seeing maybe 5 or 10% of patients who come in with symptoms will have a positive EGD. But these symptoms here, you'll see throughout this talk, are very important. When you see the alarm symptoms, these are indicative that indications usually bypass 24-hour pH monitoring, manometry, and other non-invasive studies to move right on to endoscopy, and that is age over 50, weight loss, anemia, vomiting, history of upper GI malignancy. So if you see these symptoms, you usually can circumvent all the other algorithms and move directly to EGD. Those refractory to therapy, especially PPI and H2 therapy, surveillance of Barrett's, very important, although usually the GI guys do that. You need to know that that's an indication for EGD. And long-standing reflux symptoms. Also to look at the anastomosis you may have created. Morning, Dr. Delafontaine. Glad you could make it. Contraindications, hemodynamic instability that need resuscitation. You don't want to take a hypotensive patient back there and you end up having to give them some Diprovan or propofol and they drop their pressure. If they're hypoxemic to start off with, they're going to get worse with conscious sedation. Any arrhythmias, and that includes new onset atrial fibrillation, any multifocal PVCs. Chronic AFib is not a contraindication to this. And obviously esophageal perforation. What do you find at EGD? This is a busy service. This is a surgical service, actually. It talks about what they found during EGD. Now, this is the non-hospitalized patients. Obviously, the hospitalized patients, you're probably going to have a higher find factor. But gastritis is the most common. Duodenitis, so you look at the three top, they're all inflammation of the upper GI tract. Ulcer and malignancies are way down at the bottom. So we scope a lot of people. Do we find a lot? Not usually. Some of the lesser indications, stenosis, people that are undergoing dilatation, suspected hiatal hernia. This is really not the way to make the diagnosis of hiatal hernia. Persistent esophageal reflux, obviously obstructive lesions, caustic congestion like we talked about last week, abdominal pain, and unexplained vomiting. procedure, okay, y'all been in the suite, you know what you have to do. Conscious sedation needs to be given by someone who knows what they're doing. Just giving little hits of Diprovan and propofol or whatever you're using is very important that they have airway, they have monitoring, they have oxygen saturation. You check for locks on the endoscope. If it's locked and you take it down the cricopharyngeus, you're going to perforate something. So make sure that scope can easily bend when you put it in the oral pharynx. Lubricate the end of the scope with the gel, but not too much. If it gets into their windpipe and they're awake, they can aspirate and actually go into respiratory compromise because of this real thick gel. So just use a little bit. Don't put it near the lens, obviously. So in the mouth. Now we used to use, at least when I was training, a blind technique. The patient was on their left lateral decubitus, put the scope in, and you tell them to swallow after conscious sedation. Well, you'll find obstruction in almost every avenue, and it's very difficult to do it without direct visualization of the piriform sinus. You can damage the cords. You can actually put it down the vocal cords. You can tear the piriform sinus, and most importantly, you can tear the cricopharyngeus, which has a tone of about 60 millimeters of mercury. And so when you tell these patients to swallow, their upper reflex is for them to tighten up their GE or their cricopharyngeus. So you got to be very careful. So don't use the blind approach anymore. I used to use it. I still use it for transesophageal echo. But when you have a scope and you can look and see the piriform sinus, please use it to try to go posterior to the epiglottis, back into the esophagus. Then start insufflating. Most people insufflate before that. It makes the patient real nervous. But once you get past the cricopharyngeus, and you can feel that, don't push it past about 15 centimeters or 11 centimeters in some patients. You're gonna perforate. So very important to take it nice and easy. If you can't get it the first time, a little more sedation, and ask the patient to try to do the best they can do to swallow it. Observe the Z-line in the distal esophagus. This is where all the stuff happens usually. Esophageal reflux will push that Z-zone proximally. And what the Z-zone is basically a salmon-colored appearance of the distal esophagus. And if it's more than 3 centimeters, it's indicative of columnarization or gastrification of the distal esophagus or Barrett's esophagus. So if you see that, that should set off some important things in your mind that this is a premalignant condition. Just pay special attention to the mucosa before you pass the scope and going into the stomach, because if you create tears, you create grade 1 esophagitis. And you tell this patient they have a class A or a grade 1 esophagitis, and they really don't have it. Afterwards, go by and see your patients. Make sure they don't have any subcutaneous emphysema. Ask them to hit the high notes so you know that you haven't hurt their cords. And examine their neck and make sure they feel okay. You can perforate and tear the hilum or the capsule of the spleen by very aggressive retroflexion in the left upper quadrant. This is the Z-line in someone with esophagitis. This is more proximal than it should be. The GE junction is right down here, and this salmon-colored appearance is not normal. That's from chronic reflux. And that's when you'll see your gastroenterologist that'll biopsy 3 or 4 quadrants randomly to look for high-grade dysplasia. High-grade dysplasia is a prodrome to esophageal cancer. And like I told you guys last week, the pathology of esophageal cancer has moved from the mid-esophagus squamous cell now to the GE junction, which is adenocarcinoma, because of obesity. As the obesity level rises up, the more GE junctions, cancers you're going to see. This is Los Angeles classification GE reflux. I'm not going to go into that, but the Los Angeles classification is what the gastroenterologists use as far as what they see when they look in the distal esophagus. Small tears and just minor esophageal erosion. B, you see columnarization proximally. C, tears along greater than 50% circumference, and this looks like a lead pipe in grade D. And this is chronic esophageal, and I guarantee there's dysplasia in most of, this is Barrett's in C and D. Everyone know what Barrett's is? I'm going to kind of go over what it's basically the columnarization or the gastrification, proximal movement of the gastric mucosa into the distal esophagus. It happens in about 10% of people with chronic reflux, and about 10 or 15% of those people with chronic Barrett's will have either high-grade or low-grade dysplasia, which needs to be monitored very closely. Esophageal stricture, when you get down there, this is bad news here. This is, most patients will end up having to have dilatations, 4-quadrant biopsies, and a possible esophagectomy. Anybody know what this is? This is in the distal esophagus. Leiomyoma, correct. This is a subcutaneous growth that's amenable to thoracoscopic or open operation where there's a benign leiomyoma in the mucosa of the esophagus, and it can cause obstructive symptoms. You don't need to biopsy it, just the appearance here and also the appearance with swallow will show that. It's a very neat case. You go in and it's like the olive on the patient with pyloric stenosis. You go in and just pluck this out of the submucosa. Very gratifying case, as long as you don't get into the mucosa. You retroflex your scope when you're in the stomach. You can find the hiatal hernia. This is it right here. It's a subcompact area of the cardia and is up very high as you can see, and sometimes it's associated with what's called a Cameron ulcer in this region, which is more indicative of a pathologic reflux. All right, any questions about EGD? How many have done EGDs? Raise your hand. Okay. Are you feeling more comfortable? Oh,
Yes, sir.
Okay. So introducing the scope, most important thing, watch for resistance there. I know when I put the TEE probe in the operating room, they're asleep. But you look at the size of these probes, and swallowing this thing would not be an easy issue. Okay, motility disorders. This is on most everyone's exam, general surgeon, thoracic surgeon, because you see it, most of the gastroenterologists see it more frequently, but you're referred patients that may have this, that if you end up trying to do an esophageal procedure on, you may be not doing them a service. Okay, so we're going to rock and roll through this. There's three primary disorders. We're going to go over the upper esophageal disorder, which is a swallowing problem. Most of the ENT doctors see this. Primary disorders are achalasia, diffuse esophageal spasm, nutcracker esophagus, and a hypertensive lower esophageal sphincter. Those are the ones you're going to see on your exam. And you need to know a normal manometry, and we're going to show you here in just a second. Secondary disorders of the esophagus, obviously scleroderma, diabetes, Parkinson's, stroke, and candida, and HSV. Herpes simplex virus of the esophagus can also occur. And there's a subset of patients that just don't have good mobility. They can't propel that bolus of food down the esophagus, and some of these patients, we don't know why. But what you see is the distal esophageal peristaltic amplitude is less than 30 millimeters. Failed peristalsis, absent peristalsis, and the food just sits there, and they get megaesophagus very much like achalasia. Okay, the physiology. We all know what the esophagus is for. Primary peristalsis is the primary wave we look for in manometry. It's that it's an involuntary wave of muscle contraction in that mid-esophagus that propels the food down, and it goes about 2 centimeters per second. This can be delayed in some disorders. Secondary peristalsis is when you reflux or you hiccup. It pushes locally, so it's a local reflex to push that bolus or whatever's in the distal esophagus back into the stomach. Very important, primary and secondary peristalsis. So the normal phase is voluntary. You swallow. The involuntary phase is the upper esophageal sphincter relaxation. So when we tell that patient to swallow, they may not be able to do it, may not be able to pass the scope because that upper esophageal sphincter has to open up on its own. They can't make that open up. And if they have a stricture there, obviously, or some kind of cervical spondylolisthesis or some sort of bony issue at the cervical esophagus, that could be problematic. The peristalsis begins. The primary wave starts pushing it down into the stomach. So the upper esophageal sphincter prevents air from entering the esophagus during inspiration, and it prevents esophageal reflux at the upper level. The lower esophageal sphincter prevents GE reflux in the lower aspects. Classification as far as the motility disorders, poor relaxation of the lower esophageal sphincter is classic achalasia, and the lower esophageal relaxation issues. Uncoordinated contraction, diffuse esophageal spasm, and hypercontractile is the nutcracker esophagus, where you see waves going through the roof as far as how this esophagus tries to propel the food bolus down. Okay, this is, I think, one of the most important slides, because if you know the normal manometry, you can know the abnormal manometry. So this is where a pressure probe is placed into the esophagus. They normally stop all their H2 blockers and their protein pump inhibitors prior to this. So this is the normal esophagus. Very tight up here. Look how tight the resting pressure is in the upper esophageal, about 70 millimeters of mercury. That's pretty tight. Trying to push a scope beyond that it could be problematic. But the reason it's tighter here than it is down here was trying to protect the upper airway. So the upper esophageal sphincter is a physiologic sphincter, and it does prevent reflux. So that's why this is so tight. This is why it has a high resting tone. And as you get down to the lower esophagus, the resting tone is close to 0. And when you get into the lower esophagus, once again, it's about 30 to 40 millimeters of mercury to prevent GE reflux. So any abnormality will show in this normal manometry when a probe is placed or when the pressure probes are placed. Any questions about this? This is very important. Now what happens when you swallow, this goes to 0, the upper esophageal sphincter, allowing the fluid bolus, and then it tightens up almost to 150 to kind of push the food bolus down. And then as the food bolus propagates down the esophagus, you can see it just like a snake, like a boa. You've seen the boas that swallow something and that muscle pushes it through. That's exactly what our esophagus is doing. And as the lower esophageal sphincter is approached by the fluid bolus or the water or the fluid, it relaxes down to 0. And then it gets a little hypercontractile afterwards to prevent reflux. So that's the physiology of the esophagus. Very important. Some of these motility disorders here are shown. This is the normal waveform that we just discussed. The nutcracker esophagus, just random waves with very hypercontractile pressure in the esophagus. This is a tough diagnosis to make, but it's almost always manometry. And these are in excess of 100 to 150 millimeters. People really feel this. Diffuse esophageal spasm, a lot of little bitty contractions, usually around 50 to 60. These patients also come in with chest pain with the differential diagnosis of what we talked about earlier. And then achalasia has low intensity waveforms and a high resting basal tone in the lower esophageal sphincter. So it goes down slow, it doesn't empty, and it just pools there over years and years and years of symptoms. And we'll review that in just a second. All right, this is just another slide showing diffuse esophageal spasm. Most of these are made by the gastroenterologist. The achalasia, nutcracker esophagus, and usually are not referred those patients for esophageal surgery unless it's an achalasia patient, if you get those. So the differential diagnosis, if it's recent, rapid onset, think of some kind of infection in the esophagus, particularly in an immunocompromised patient that has odonophagia, dysphagia. It hurts to swallow, especially when Candida. Y'all have seen patients with Candida in the oral esophagus, how tough it is. It feels like they're swallowing pins and needles. So think of Candida, CMV, HSV, and gastroesophageal reflux, especially in the transplant patient. If it's persistent and intermittent, if this can be corroborated with pressure monitoring, it's usually a motility disorder. If it's progressive, think of something that's affecting the esophagus itself, like scleroderma, achalasia, Chagas disease, and things like that. So the spastic motility disorders use manometry. You can use barium esophagram to see if you have a shortened esophagus, and it'll also show you the wave or the epiphrenic diverticulum or things like zinkers that occur in the upper esophageal sphincter. Endoscopy and pH monitoring. You have to use pretty much all that you have in your armamentarium to make the diagnosis of a spasm because it's tough. It's usually a diagnosis of exclusion. So the treatment in these patients, when you see this many treatments, there's usually no good one treatment. So reassurance, nitrates, all unproven, calcium channel blockers. When you see psychotropic drugs and something like this, you're really not sure what you're doing occasionally. And then the dilatation has placebo effects but really doesn't help the patient. So it just usually occurs in patients of any age, dysphagia to solids and liquids. It could be intermittent and non-progressive. And when these patients come in, this is the differential diagnosis of STEMI, pancreatitis, things like that. You just don't know what's going on, but they're having dramatic chest pain. So the motility disorders, what we use is barium esophagram, manometry, and endoscopy. Talking about the upper oropharyngeal dysphagia, normally when we think about this, we think about Zinker's diverticulum because that's what we were presented with. When someone has this in a long-term symptomatology, they're sent to us with potentially a Zinker's. The ENT doctors do this, the thoracic surgeons and the general surgeons can take care of this. Those patients that have difficulty swallowing also, you have to think about stroke, Parkinson's, polio, rare ALS, multiple sclerosis, myasthenia, things that can cause dysfunction between the brain and the upper esophageal sphincter. Hypertension of the cricopharyngeus and achalasia of the cricopharyngeus has been described. And this is a Zinker's diverticulum. It's a posterior outpocketing just distal to the cricopharyngeus. You can go in, and there's several ways of doing this. Some people do it through the scope. Some people do it transoral. The gastroenterologists do that. The classic approach is a left cervical incision, going down and either pexing this, in other words, raising this up where it empties into the esophagus. You have to do a release of the cricopharyngeus muscle. If you've never seen it, it's hard to release it, but there's definitely a band in this area. I resect these. If they're over 3 centimeters, it's better to resect them. If they're small, you can lift it up and pex it to the cervical spine. Something strong that'll lift this thing up and it'll empty directly. Now, the problem with that, the recurrence rate is higher. Resecting it, the recurrence rate's lower, but it can be associated with some stenosis of the cervical esophagus. Achalasia. This is the big thing that surgeons see. Dr. Delafontaine and I did an extended operation on a patient, a young gentleman who lost about 100 pounds, if I remember correctly. He had it for about 10 or 15 years. First clinically diagnosed in the 1600s, believe it or not, coined the term in 1929, and it's a dual disorder. The lower esophageal sphincter does not relax, and there's a higher tone. Remember, with the 30 millimeters of mercury tone, it's closer to 60 to 90. It's not a spasm, but it's a continued lower esophageal tightness, so to speak, and the pressure there can be measured through a manometry. Loss of peristalsis in the distal 2/3 of the esophagus is important, and this is the bird beak sign that you see on esophagography. These patients also have to have motility studies. They have to have EGD to rule out occult carcinomas here. You have to use the whole gamut prior to operating. And most of the gastroenterologists will say, before you operate on a motility disorder, they've almost all had EGD, manometry, pH monitoring, and some of the more esoteric tests that they're using now to study the motility of the esophagus itself. Still very rare. Most thoracic surgeons see one of these a year. General surgeons probably close to the same. And most importantly, for your examination, it's a loss of the myenteric plexus in the distal 2/3 of the esophagus. So it loses its ability to push that primary peristalsis down, which causes stasis of food there. Really don't know what the cause is. Is it autoimmune? Is it an infection? Has the infection caused the problem with the myenteric plexus? Solid dysphagia. They have postprandial regurgitation. They had chest pain, weight loss, and dramatic weight loss too. It could be 30, 40 kilograms. The diagnosis by plain film, you see an air fluid level. Barium esophagram is almost diagnostic, but without esophageal manometry, I would never operate on these patients. You have to show elevated sphincter tone in the lower esophageal sphincter with the inability to relax. And also endoscopy will help you to see exactly where the cutoff sign is, where the lower esophageal sphincter is located. Treatment, nitrates can be started. These are usually ineffective. What I have normally seen that they've had Botox injection, which has been very effective. This is almost a provocative test. If they get Botox and they get better, the chance of them having achalasia, even with a equivocal manometry, is very high. So it's therapeutic and provocative to help you make the diagnosis. Most patients have had pneumatic dilatation and a surgical myotomy, extended myotomy of about 8 centimeters. This can be done through, very important, through the thoracoscope. It can be done through the laparoscope, and it can be done open. So those are the 3 methods. What's the most common in the United States? Laparoscopy. Now, the problem with that is trying to get up 8 centimeters proximal in the esophagus through the laparoscope. You can do it easily through the chest. And if you don't do some sort of wrap after this procedure, the incidence of developing severe reflux is almost 30 to 40%. So if you're going to do this and you do the extended myotomy, it's probably a good reason to do a wrap after that, either a localized door or a toupee. Most people do not do a full Nissen fundoplication after this. And there's other motility disorders involving the body. Barium esophagram, EGD, and once again manometry are those things that help us. Some of these overlap. Diffuse esophageal spasm and nutcracker esophagus overlap. Very, very few indications for surgical procedures in this right here. Most of these are medical or Botox. Achalasia, number one, is the number one indication usually for the thoracic and general surgeon. You get into some of these, if you don't have the diagnosis and you've done this and the patient presents with recurrent symptoms, even though you may have done a long esophageal myotomy, not very good for the patient. So you're seeing less and less surgical indications for these motility disorders unless it's achalasia itself. discussed this. Hypertensive lower esophageal sphincter is an entity by itself. It's not really achalasia, but it borders on the diagnosis, and the treatment of this is usually medical. Once again, the high amplitude of the nutcracker esophagus. I have seen a patient that presented with, we thought, an aortic dissection. She had a chronic dissection and actually had nutcracker esophagus after about a week workup. This was a chronic dissection. It probably didn't cause her pain, but it was her esophagus, and she got better with some nitrates. Diffuse esophageal spasm. This is the esophagram that shows what you see. This is quite painful too. All right, we're going to review. This is the last segment of this talk today. We've got about 20 minutes left, and we'll go over some questions after this. Esophageal reflux surgery. Unfortunately, this is becoming less common as time has gone on because the gastroenterologist and others have taken a very advanced look at how they can do it without an incision. Transoral, endoscopic myotomies, and procedures for anti-reflux is really taking its toll on the surgical patient, or taking its toll on us for getting these cases to do reflux surgery. And we want what's best for the patient. And some of the studies are still early as far as some of these transoral procedures to help with reflux. And still the maintenance of therapy and is still proton pump inhibitors for the patient with reflux. And we'll go over the complications of reflux and when surgery is actually indicated. Everybody should know what GE or GERD or gastroesophageal reflux is. It's a condition when the lower esophageal sphincter doesn't close in the stomach. The contents leak back. It can be bile, it can be acid, it can be a combination of both, and leaks into the esophagus. And once again, with the obesity that we see in the United States and worldwide, everybody's seeing increased Barrett's esophagus. They're seeing increased complications of GE reflux, whether it's strictures, whether it's adenocarcinomas of the distal esophagus. With the world approaching 30% of our population being obese, it doesn't even include the morbidly obese patient population. You're going to see more and more adenocarcinomas of this area. What causes it? Strangely enough, we don't know. We know a lot of symptoms are associated with it, hiatal hernia, certain symptoms, but when you really get down to it, what the pathophysiology is, we don't know, because there's some very skinny people who have gastroesophageal reflux and have the complications of GE reflux without obesity and without hiatal hernia. So there's a spectrum that it crosses all populations, but obviously it is associated more so with patients with hiatal hernia and obesity. How is it treated? Well, we're a lazy population. We're a lazy world. Lifestyle changes could really change probably 65 to 70% of GE reflux, but we just don't do it. We keep drinking and eating late at night, usually 3 hours prior to us going to bed. We won't elevate the head of our bed. We won't lose weight. And we continue smoking, things like that could dramatically improve on the changes of GE reflux. Most of the patients that I have seen with this have said that just a 10-pound weight loss dramatically reduces their chance of GE reflux or their symptoms of GE reflux. Medications are really the mainstay of treatment now. 85% of patients with GE reflux are treated with medications and attempted lifestyle changes. And those that get surgery are the ones that don't want to change their lifestyle and are not compliant with their medications. So this is a treatable disease, but when it's not treated appropriately by the patient, they have to take some skin in this. And if they don't, the complications then are headed toward the surgery or the endoscopic options for treatment of GE reflux. Very prevalent, 20% of adults. The obesity rate is 30%, so that tells you this has gone up from about 10% of the population and has doubled over the last 2 decades. Heartburn and regurgitation are the mainstays, or the symptoms that we most commonly hear. There's 3 algorithms that I have here, and all of them will show you how much more of a diminutive role surgery is playing in GE reflux when you look at the final recommendations at the bottom. But they all start with heartburn and regurgitation symptoms. They're usually seen by a primary care doctor. If they have any of those alarm symptoms that we talked about, weight loss, older than 50, family history, any bleeding, odonophagia or dysphagia, they go directly to endoscopy. That's heartening to see, because most of them if there's no alarm symptoms, they go directly to proton pump inhibitor therapy. And you would be amazed. If you look at all these algorithms, if they still have persistent symptoms, they double dose it. If they have resistant symptoms, then they get scoped. They get manometry and pH monitoring. If the symptoms resolve, they never look in the esophagus. This has changed over the last 20 years because endoscopy played a much quicker role. But if you look at the false negatives of endoscopy, and you saw that initial slide of what we find during endoscopy, it's very rare to find something that's going to require therapy other than proton pump inhibitors. So a mainstay of therapy is still maintenance therapy with these PPIs. If it's positive for acid reflux, when they have recalcitrant or resistant GE reflux symptoms, you once again try to optimize their acid suppression. Then you consider reflux procedure, whether it's a transoral or a surgical. If it's positive for non-reflux, actually for bowel reflux, Nissen is probably the standard of care still. Negative for GE reflux, you think of some functional abnormality. This is another algorithm that doesn't even have surgery in it. There's no surgery down here at all. Some of the gastroenterologists think it's not a surgical disease unless you have Barrett's, stenosis, or cancer. That's not thought of by the general population, but some of the aggressive gastroenterologists fail to recognize, or they've had patients with Nissens that have gas bloat or have had some complications of their operation that don't refer them. And you're seeing more and more of that. This is the last algorithm we'll go over. This is the treatment of gastroesophageal reflux. Typical symptoms, PPIs for 6 to 8 weeks. If it recurs less than 90 days, they get scoped, and then you think about some other possibility of repair. If it recurs after 90 days, they go back and get another PPI regimen prior to EGD even. PPIs are not without their own complications. Some people think there's an increased risk of cancer. Some people think there's increased risks of esophageal issues themselves. So some people, after reading in the lay literature, they quit taking their PPIs, and it shunts them in more to a mechanical fix of their GE reflux. So here's the indications for endoscopy by most gastroenterologists with GE reflux. And these are very much like the alarm symptoms we talked about. Persistent and progressive despite appropriate medical therapy. Most of the algorithms show almost 2 months of treatment with PPIs prior to this. Dysphagia or dinophagia, involuntary weight loss, any coffee ground or anemia, guaiac-positive stools, finding of a stricture mass on other imaging studies. Screening for Barrett's, very important. And vomiting, recurrent symptoms after an endoscopic or surgical anti-reflux procedure, or the placement of a pH monitor. The non-surgical procedures that they're doing now, you may have seen the LINX procedure, which is a circular metal magnet group that are placed laparoscopically around the distal esophagus. Some of the early results are actually fairly good. There's also some procedures transoral that they're using for fundoplication. It's an incisionless. They go through the esophagus with a scope, and they'll place some either radiofrequency therapy to the distal esophagus to try to cause somewhat of a scarification to create the lower esophageal sphincter. That's in Europe, that's a real common thing that they use for gastroesophageal reflux. And there's some where they place little stents up at the GE reflux to try to reform that angle of His at the angle of the esophagus to recreate the valve function of the lower esophageal sphincter. And that's what the gastroenterologists, that's why a lot of the Nissen referrals and GE referrals have gone down dramatically in the last several years. So the diagnosis, symptoms first, responsive symptoms to empiric therapy, or the lack of response of this empiric trial, and then ambulatory esophageal pH monitoring, and at the end, EGDs. Esophageal pH monitoring probe, this is strictly for your examination. Obviously, we don't do this study. It's a gastroenterologist, but they place a probe that's got a pH monitor 1 centimeter below the upper esophageal sphincter, and then 5 centimeters above. They get them off all their proton pump inhibitors prior to that, and they look and see how much the patient, especially during symptoms, they have a little diary that they place on when they're having reflux symptoms and try to correlate it with pHs of less than 4 and how long it stays less than 4 in that specific portion of the esophagus. Here's a test. It's a gold standard for the presence of pathologic reflux. Unfortunately, there's some patients that have absolutely no symptoms that have these pH drops to 4. Here we have a heartburn here. The pH drops dramatically. There's no symptoms here and no symptoms here. We don't quite understand why, but for some reason during this evidence of reflux, the patient had heartburn here and here, but you can see about 5 minutes prior to that, the heartburn started. And this is actually a cough that's associated possibly with reflux. So this is something that can be used as a corroborative study that they have reflux, but it's not something that would make you or make you not operate on this patient. It would have to be correlated with EGD and with some other studies. Limitations are as follows. It's not accepted by patients easily. This thing has to kind of hang. It used to have something hanging out of your mouth as you kept this probe down. Now there's some non-tethered monitoring that they can place in the stomach. The false negatives, once again, can occur as patients that have a significant amount of symptoms and not have any drops in their pH. And then there's some patients who have a positive test. They really can't find a causal relationship with their heartburn or with their cough. This is what you find in patients with reflux disease. Not a very, I would have expected this to be endoscopic positive much more. Patients, and this is several studies that show how often do you find actual reflux, those Los Angeles classifications 1 and 2, in patients who undergo endoscopy? Pretty rare. It's not as common. You would think it would be up to 80-90% that you would find patients with reflux symptoms that would have symptoms on their EGD. Not necessarily so. That's why you have to use an entire constellation of studies, pH probes, symptoms, reaction to PPI therapy, and endoscopy to see if these patients need surgical therapy in the long run. All right. Types of fundoplication. There's several historically described types of wraps. The 360-degree wrap is the Nissen, which is the most common. The toupee is a 240-degree wrap posteriorly. The Hill is a posterior gastropexy, and the Belsey Mark IV is a transthoracic procedure that can be done laparoscopically. But what they're trying to do is trying to basically minimize the amount of gas bloat. Nissen is very effective to prevent reflux, but it's associated with gas bloat in about 15 to 20%. These other lesser procedures have less gas bloat. So you're basically trading off one for the other, but it's not as effective of reflux operation as the Nissen itself. This is just a handwritten or hand-drawn procedure of the Nissen fundoplication. First thing you have to do is you have to reduce the hiatal hernia. You have to reintroduce 3 centimeters of the esophagus below the diaphragmatic hiatus, tighten up the hiatus, and do the 360-degree wrap. Most people would say that you have to take the short gastrics away from the spleen. If not, you're going to have a leaky wrap, or it's going to float on you, and you're going to lose the tension around the esophagus. Most importantly, is you have a bougie of about 50, 55 that goes down the esophagus when you're doing this. This is the 360-degree wrap here, which is the Nissen fundoplication. This is the anterior wrap. Most people do not recommend nowadays because of its ineffectiveness and the increased chance of recurrent reflux. And then the posterior wrap here, the toupee, and the door procedure. Just laparoscopic type of procedure for the Nissen. Take down the short gastrics, try to get mobilization of this entire stomach. You want a floppy wrap. You don't want to where it's inhibited, where you can't bring the esophagus, the interthoracic esophagus, and reduce the hiatal hernia. You'll have to expand the hiatus, and the frontoesophageal ligament has to be taken down. Pull the stomach down so you have at least 3 centimeters of intra-abdominal esophagus to recreate that the bowel function. And tighten up the posterior area of the hiatus, the esophageal hiatus, and then perform your wrap. And there's the bougie here, which helps you and prevents you from over-tightening the esophagus itself. 85% of these Nissens can be done laparoscopically. They don't have to be done open. Here's some of the complications you have with fundoplications. Recurrent reflux happens in about 10 or 15% of the patients, and a quarter of these patients are still on proton pump inhibitors after their therapy. And that's why the gastroenterologist said, I'm dismayed with this operation. they're still on anti-reflux therapy even though you've done the Nissen fundoplication. Thus, the new interventions through the transoral incisionless route. Abnormal fundoplication, if it's too tight, which can happen without appropriate bougie introduction into with the operation itself, you get crural stenosis, structural obstruction, and this is where you get the gas bloat. And this is where the patient, you get a patient that has a bad Nissen, you'll never get rid of them, I can tell you. They're very unhappy because they can't reflux, they get gastric dilatation, they can't burp, they can't reflux and get some of that gastric filling. And they all come in and say, look, when I eat, I don't feel like I can burp. I feel full. And that's classic symptoms of gas bloat. It really needs to be investigated. So it's not without its own symptomatology, and that's led a lot of the gastroenterologists to abandon any kind of reflux surgery. And if you look at the number of Nissens that have been done over the last 2 decades, the last 8 years there's been a reduction of almost 50% of gastroesophageal reflux surgery. So it's our duty, if we do this operation, to do it right. It really needs to be in the hands of people that do foregut surgery a significant amount of time. And it needs to be done minimally invasive. You can't do open procedures nowadays and compete with gastroenterology procedures such as the links and some of the other oral incisionless procedures. So when you do these, make sure they're done right and do them with somebody who's experienced where you can get your learning curve up. And it takes about 50 or 60 cases through the laparoscope to do that. Any questions? We've got 5 minutes for questions. Stop you. Yeah.
I have a question. So the reading has some stuff about what to do if you only get 1 to 2 centimeters. You don't get the 3 centimeters.
Right.
And I'm a little confused because it talks about the hollis versus the wedge.
Right.
And when I looked online separately, people use them interchangeably, and so I can't tell what the difference is.
Well, I didn't cover esophageal shortening, but a lot of these patients with chronic symptoms, the stenosis they get, the reflux they get, shortens the esophagus by 2 or 3 centimeters. And Rachel's exactly right. If you don't lengthen the esophagus, you can't get it down. And it'll pull right back up into the chest. Recurrent symptoms, gas bloat. So hollis is important. And what that does is basically lengthens the esophagus so you can pull it down. And you have to lengthen it circumferentially. So if you don't lengthen it, and most people, the area that people avoid is near the aorta. That's where you can get into danger. But if you go posteriorly with the scope, you can pull it off of the aorta. There's some tight adhesions there. But if you don't go up into the chest with your scope in the abdomen, you're not going to lengthen it, and you're going to have a failed Nissen. That's when some people would do a kind of a combined thoracoscopic and abdominal approach to lengthen with a heel or a posterior gastric or stomach esophageal release where they can bring it into the stomach itself. So you got to have esophagus. You got to have 3 centimeters. If you don't, and if it's not floppy and loose, and if it's tight, and you see that wrap hiding right up under the diaphragm, it's going to fail. It's going to fail because what it'll do is your wrap will evaginate, and the esophagus will rotate back up into the stomach, and you'll get recurrent symptoms. Any other questions? How many have done Nissens? That's that foregut surgery. We really need to, see what we can do with the department to get somebody where y'all can do these procedures. Are they doing them at Willis-Knighton? A fair number at Willis-Knighton? That's what I thought.
The pediatric surgeons have done that.
Right.
And then Dr. Norwood does them at Willis-Knighton.
He's
We
an
can see, we can observe him, but we're not.
Yeah. It's something I know Kevin, we used to do a lot of Nissens here, didn't we? Done a lot of it. Any other questions? All right, thank y'all for your attention. Nobody fell asleep during the esophagus, especially during the motility disorders. That's amazing. So, thank you.